So Dr. Vanashree will be talking on understanding the higher order aberrations and role of aspheric intraocular lenses for better outcomes.
Yeah, so we are using aspheric IOLs since more than a decade now, but many a times we not really understanding what these aspheric IOLs are really doing, what were they developed for. So I would just like to cover up what are the aberrations that we deal with in every patient and how we are trying to reduce the effects of these aberrations in the eye so that we give a good outcome to the patients. So higher order aberrations and how the aspheric IOLs are having a role in cataract surgery. So in cataract surgery, or rather now refractive cataract surgery, we need to understand the overall optical aberrations of the eye to find out the best suitability for the patient needs and what suits the patient. We are using a lot of premium IOLs, multifocals, trifocals, EDOFs, torics, but how do we really plan for the patient depends on what pre-existing conditions are there in the patient. So very basically, what are these aberrations in the first place? So they are lower order aberrations. The 90% what we have is defocus, that's your myopia and hyperopia and astigmatism. And 10% are the higher order aberrations, which is spherical aberrations and coma. These are practically relevant to the general population. Now, a perfect optical system that does not exist in the eye, but a perfect optical system is the one which is not having any aberrations. So a wavelight, when it is passing through optical system, it is going to get aberrated. If you can see that, if you can appreciate the diagram, so that it does not focus to a point. So it will have a spread. So this wavefront which is going, which is like, like a not a perfect curve, will have some undulations. So these need to be measured. So that is what we are doing when we are measuring the wavefront aberrations. So we are doing that with the help of wavefront aberrometer. So there are two types, Hartmann-Shack and the sharing type. So here you can see the 3D map of it, of wavefront, how that is getting formed. So now we need to quantitate it. We are seeing it as a wavefront, but how do we quantitate it? How do we actually use it? So we quantify it using the Zernicke's polynomials. So these are mathematical equations. Again, they look very daunting to us. But the idea is that the wavefront, which is the reference plane, is going to be in green. The part of the wavefront which has gone beyond is red, and the part which is behind is blue. So diagrammatically, we get an idea that how the wavefront looks. But it is quantitated using root mean square error. That is the average deviation of the measured wavefront from the ideal optical system, which will not have aberrations. And the second system is the Fourier analysis. So Zernicke, I won't go into the very details of this. So if you see this diagram, so the perfect wavefront, if it is a straight line, so some aberrated wavefront, part of it is ahead, so that is calculated as plus. Some will go in minus, again some in plus. So we take a root mean square of these aberrations so that the minus and plus values are gone and we have a finite figure with us. Now there is a very nice instrument called the eye trace, which gives wavefront analysis, it gives the topography, it gives us the keratometric readings, autorefractor, pupillometry, everything put together so that we can analyze these aberrations well and use it practically when you're planning a cataract surgery patient. Not everyone will have access to eye trace, so even the basic tomographers, like the pentacam, will give us the wavefront analysis, the root mean square value of the aberrations which are practically relevant to us. So this is how the eye trace readings look. So the most important one is the spherical aberrations in our practice. This is the fourth order aberrations, and why it is important, because every eye is having a natural spherical aberration which is 0.1 to 0.55 microns, and it aids us in depth of focus actually. It gives us some depth of focus. So the average spherical aberration of the eye is plus 0.27. Now why it is important? So how it helps? Now if you see this diagram, right bang in the center, there is no spherical aberration. So here the image will be very crisp with maximum contrast sensitivity, but there is no depth of focus. So you go slightly beyond negative spherical aberration and positive spherical aberration in the tolerable range up to minus 0.35 microns. You have some good depth of focus with a slight, contrast sensitivity decrease, but that is tolerable. And there is a range which is up to non-toxic. So here you will have maximum depth of focus and it will still be non-toxic. So that depth of focus will actually aid in your near vision. And beyond that is a toxic range, where the spherical aberration is so high that it is going to cause glares, halos, and those issues. So this range of 0.6, minus 0.6 to plus 0.35 is the neural adaptation range, which this spherical aberration is actually going to help to keep the image clear for near, giving a depth of perception. So this diagram again, explains the same thing, that when there is a sharp focus at one particular point, only when the image is focused at that point, the brain will perceive it as a clear image. And if the image goes out of focus, the brain will see it as fuzz. So there's no depth of focus here. But if you have some spherical aberration, so what is happening, you're getting a range of vision. So when the object moves in that particular range, you'll have some depth of focus and the image still remains clear. Now, how does it apply to cataract surgery? So what happens is, in a young patient, actually the cornea is having a positive spherical aberration. The lens actually gives a negative spherical aberration. So totally there's no spherical aberration and the image quality is very sharp and clear. In the middle age, say around 45 years, the cornea is still having the positive spherical aberration. The clear lens, the spherical aberrations have almost come to zero. So there is a overall total mild positive spherical aberration, which is giving an increased depth of field where the accommodation is slightly getting lost now. Now in an aged eye, where there's a lot of cataract present, both the cornea and cataract are going to give a large positive spherical aberration, so the image quality is going to deteriorate. Now what happens when you put a standard IOL? Now a standard IOL has a lot of positive spherical aberration. So the total positive spherical aberration becomes quite a lot, so the image quality is going down. If you use a zero spherical aberration IOL, they have a mild positive spherical aberration. So they'll have little depth of field, but still the quality of image is not very sharp. And a negative spherical aberration IOL, what we call as the aspheric IOLs, these are the zero aspheric IOLs and the negative aspheric IOLs, they give the maximum clear image, but the depth of focus will be lost. So how does it actually affect? So this is a diagrammatic representation of if you're using a spherical IOL, then that's how the image quality is. And compared to an aspheric IOL, you get a sharp image. So traditionally, the IOLs are positive spherical aberration, zero aberration, and negative aberration. So in aspheric IOLs, basically the thing is the spherical IOLs, they have a same power on the lens. So it causes not a single point of focus. They're easy to make, but they'll have a lot of positive spherical aberration. Whereas the aspheric IOLs are more difficult to make, but they'll give you a sharp focus on the point. So that's why they give you a sharper clarity, but depth of focus is lost here. So the same thing again. So where does it apply now to us is many patients are going to be your post-refractive surgery patients. In the future decades, we'll be having more patients who will be having rather patients who have had refractive surgery rather than having virgin eyes. So it is important to make sure that you find out what kind of LASIK the patient has undergone. If it was a hyperopic LASIK, then the cornea is going to become more steeper here. It's a hyperprolate cornea. So the cornea is already having a negative spherical aberration. So here you should not use an aspheric IOL and use a standard IOL. Whereas in a myopic LASIK, it's a flat cornea. It has a lot of positive spherical aberration. So here your aspheric negative IOLs help. So coming quickly to the examples. So negative spherical aberration IOLs are your Technis, Vivinex, Alcon, Acrysof ones. And zero aspheric IOLs are your Bausch & Lomb, Envista. And traditional IOLs are your Sensor and the other lenses. Take home points, target the lower order aberrations first, then focus on the higher order aberrations. Important higher order aberration is spherical aberration. Do the tomography to find out the total higher order aberrations. If it is more than 0.4 RMS, avoid multifocals or true EDOFs. And if the chord mu or chord alpha is more than 0.5, then avoid multifocals. Thank you.
Thank you, Dr. Vanashree. So just before you leave the podium, so could you just recap, because we are so used to putting aspheric IOLs, what are the patients in whom you would not put an aspheric IOL?
Yeah, so as I said, hyperopic LASIK patients, they have prolate cornea. So there is already a negative asphericity is there. Negative spherical aberrations are high. So if you're going to put a negative aspheric IOL, like your Technis, so the negative asphericity increases more. So you are going to offset it in a bad way. So that's hyperopic LASIK is basically you need to be careful about. Normally patients are having a positive spherical aberration, and even myopic LASIK it is positive spherical aberration. So you're safe to go ahead with the negative asphericity IOLs as well.
Any other cases like multifocal cornea or
Yeah, so other ablations, if they have been done, then you have to actually calculate the spherical aberrations using tomography and then accordingly titrate and use the IOLs.